I'm Sydney. I'm a PGY1 internal medicine resident at Doctors Hospital, and this case is entitled A Conundrum of Results, Creutzfeldt-Jakob disease or meningitis. To give you a little bit of background information, this case follows a 68-year-old female with history of hypertension and mild cognitive impairment who presented initially due to concern for stroke and who later developed seizure-like activity. She was ultimately admitted to the ICU for status epilepticus. She had a lumbar puncture on day 1, which had a CSF analysis consistent with bacterial meningitis, and so she was initiated on broad-spectrum antibiotics at that time. On the left, you can see her initial MRI from hospital day 2, which showed diffuse abnormal signals throughout the cortex with cortical ribbonning, which is characteristic for CJD. This was a surprise and the first time that CJD presented itself on the differential. She continued to have non-epileptic myoclonic jerks and failed to improve clinically despite treatment with antibiotics. And then on hospital day 11, nursing noticed new unequal pupils, and so a repeat CT was obtained, which is shown on the right and showed worsening edema with a new 8 mm shift. This slide is just an MRI comparison showing her initial MRI on the right and then the repeat MRI on hospital day 13 and the rapid progression of the disease. Given the MRI findings, history of cognitive impairment, and myoclonic jerks, CJD quickly became part of our working differential. However, it's important to note that CJD has a prevalence of only approximately 1 in 1 million people in the US population. The diagnosis relies primarily on CSF analysis and MRI findings, but can only be confirmed with brain biopsy. While there's no treatment or cure, isolating cases of prion disease is incredibly important in stopping the spread, as well as isolating sporadic cases. CSF analysis is very important in diagnosing CJD. CSF analysis consists of 3 parts, which include measuring levels of 14-33 protein, tau protein, and RT-QuIC. RT-QuIC is cerebrospinal fluid real-time quaking-induced conversion and is highly sensitive and specific for testing sporadic CJD. It's important to note that of patients who are negative for RT-QuIC, 90% end up having an alternative positive diagnostic investigation, such as CSF 14-33 positivity in the presence of cortical ribbonning and basal ganglia changes on MRI. Our patient was ultimately found to have 2 out of 3 CSF studies positive, with RT-QuIC being negative. Repeat CSF analysis was recommended, but before this was obtained, the patient's family made the decision to transition to comfort care, and autopsy was ultimately declined. Ultimately, we were unable to make the diagnosis of sporadic CJD in this patient versus meningitis, despite very sensitive and specific testing. Pretest probability is paramount to interpretation of tests such as CSF analysis, and ultimately I feel that this case demonstrates the importance of understanding Bayes' theorem and the probability of making the diagnosis of a rare disease when the overall prevalence of the disease in a population is very low.